Okay, let's talk a little bit about quality assurance. And the basic principles here is that we're going to do quality assurance programs pretty regularly. Most facilities you do them every morning before the day's work. And they're recorded. These are tests that are recorded and then documented. And so we're using quality assurance to verify that we can actually produce high quality images. So these are designed to make sure that the CT system is producing good images. Typically it's a method that's very specific, and you have to follow the method very closely in order for the results to make any sense. It's the responsibility is going to fall on both the CT technologists who are working on that scanner, as well as the medical physicists who come in and do the yearly calibration checks on it. Typically in the past, these were kind of vendor specific, so like GE would give you a certain kind of quality, a QA phantom that was just for use with GE, and you just ran the GE QA program. It was a protocol that came preloaded in the scanner, and you were good. But they're starting to look now at a standardized or universal way of measuring quality. I think the American College of Radiography has released their own separate phantom that's pretty much a universal phantom, and that's how you can get certification from the ACR that your machine is up to universal standards, not just the vendor-specific standards. So, any kind of tests they're done in a regular basis. They're done in a consistent format, so you want to make sure your techs are doing them the same way every single time, and that they're being appropriately documented. The term for that is interrelator reliability, that every single technologist is doing the tech the exact same way every single time, so that you can have a high confidence in what they're finding. Here's an example of what a QA phantom looks like, and as I indicated in our last discussion, they have different kinds of components inside of them that can be measured. Like, for example, this component down here in the what would that be, the lower right hand corner. This may be what they use for that line, the spatial frequency test, right, to make sure it can distinguish between different line sets, whereas this up here or this might be used for contrast, right? So this might be used for spatial resolution, and something like this might be used for contrast resolution. And we're going to measure it again by placing ROIs on it in different prescribed locations and reporting those attenuation values from the ROI, as well as like a standard deviation between them. Here is an example of a spatial resolution. I have seen this image a whole lot in the course of my life. And what you have to do is you have to place little star-shaped ROIs on these line pairs and then measure the attenuation values. You'll also place typically an ROI here and an ROI here. And the image itself is reporting how well it is managing temporal resolution too, or how well the rotation is aligned to the phantom, because with these little fellas on the side, you can see that those line pairs look more or less identical, like they have a long line at the bottom and then a series of short lines above. As you're scanning through the phantom, those lines are placed at different intervals so that you can make sure the phantom isn't like crooked or something in the gantry. Again, before you do any kind of test like this, you want to make sure that this phantom is directly aligned to isocenter. And so a lot of times, in addition to actually scanning the phantom, you're doing measurements on the lasers to make sure that, like, a laser is here and a laser is here. The lasers are actually in alignment with the phantom as well. You would not want your lasers to be out of alignment with isocenter or with the phantom. Contrast resolution, we're going to use the phantom to look at objects of varying density, and we're going to see if we can actually make those distinctions with our eye as well as with an ROI. it may have some spiral or wedge shapes inside of it. In that case, what we're looking at is slice thickness accuracy. That goes back to kind of what I was saying about those line pairs on the side. We want to make sure that those line pairs match up, because then I know that on each side of this thing it is the same thickness, it's at the same level. And so it is important that the machine, for example, the table is not moving faster on one side or slower on the other side, or that the gantry isn't being allowed a certain amount of rotation in addition to the table movement. Laser light accuracy, as I mentioned, we're going to do tests every day to make sure that the laser lights are lining up appropriately. Okay. So typically we are going to measure noise with just a water phantom, and it's water with some nickel or other kind of metals in it, so that it has some kind of value a little bit more than water. So if you ever drop and crack a QA phantom, I don't recommend that because they cost tens of thousands of dollars, but I also would not recommend drinking the water that's inside of them. So the noise is going to be measured by the standard deviation between the CT numbers and the ROI. Okay? And its uniformity is the ability of the scanner to yield more or less a CT number that's about the same across. Linearity. This is the relationship between CT numbers and the linear attenuation values of the scanned object. So the physicists have very specifically constructed an object, sometimes it's a cube made out of plastic. They know specifically what the attenuation value of that plastic cube is, right? They know specifically what its Hounsfield unit should be for a given scan protocol, right? Since they can specifically say this is what it's constructed of, this is what its Hounsfield unit measurement should be, we are going to scan that cube and then we're going to measure it, and we want to see a number that's exactly what the physicist predicted. Okay? So we're going to, they'll have a variety of objects with different densities. We'll place ROIs on them and make sure that those Hounsfield units correspond with what the physicist said. Radiation dose. We can use phantoms to measure what the radiation dose is for different protocols. And this is the most typical way that we measure radiation dose for protocols is we take a phantom that simulates, for example, the chest or the head in terms of its thickness, and then within that phantom we will place a pencil ion chamber, right? And we will measure at that ion chamber what the dose is at the center of that phantom during scanning. And from that point we can also measure at the outside on either side and at the top and the bottom, so we know what a skin dose is when we measure on the outside, and we know what that central dose is when we measure from the inside. These kinds of measurements are really helpful because they allow us to construct protocols that have good image quality and know specifically what the patient dose should be related to that without ever exposing anyone to any radiation. So when we're developing new protocols, we go through this exhaustive process of measuring radiation dose against image quality with a phantom before we ever start irradiating patients. So there's laws requiring dose measurements for facilities, and they will be performed by a medical physicist. You can sit there and watch them. Generally, it will take over 8 hours to do all the dose measurements for the protocols in your average CT department. So that'd be 8 hours per scanner is what I'm saying. They'll be sitting there with a water phantom on the table with an ion chamber inside of it, just getting measurement after measurement after measurement. And she mentions the pencil ion chamber. They will then compare those doses to published doses that are released every year for that specific vendor and modality and that specific model of that scanner. And the medical physicist community meets every year just to talk about CT dose. They have what's called the CT Dose Summit that they have every single year because this is such a huge part of where people get an exposure to ionizing radiation. Artifacts. Anything that appears on the image that is not there in the object that we scanned, we will call an artifact. We can see a bunch of different kinds of artifacts on CT images. We can largely classify them as physics-based, based on the physics of photon interaction with matter. They can be patient-based, the way the patient's sitting, or the presence of car keys in their pocket, or it can be equipment-induced. So there can be actual noise that's produced by the CT scanner while it's acquiring images. Beam-hardening artifacts go back to that polychromatic nature of the X-ray beam. Polychromatic is the fancy word for the colorful rainbow of spectrums of energies that are produced when we make an X-ray beam. So because it has a polychromatic X-ray beam, as certain things attenuate the X-ray beam, they can actually harden the X-ray beam, allowing only the high energy photons to pass through them. The main place that we see this kind of thing are at the base of the skull. We get a beam hardening artifact that makes it look like their brains are corduroy, right? Because all we're getting is the high energy photons that are able to pass through both sides of the skull. It's a very hard beam that is remnant. We can minimize hardening artifacts in three basic ways: through filtering the X-ray beam prior to it even entering the patient, calibrating, making sure that we're using the appropriate protocol, that the patient is at ISO center, and that the machine is calibrated appropriately. And then we can actually use software post-processing to process out that noise from the beam hardening. So there are algorithms that we can run on the image data after it's acquired to get rid of that noise. Here's an example of beam hardening artifact, and we can see they've indicated with these arrows down here at the brainstem how there's these lines. I may turn on the light so we can see these pictures a little bit better. But because of the presence of all the skull bone at the level of the temporal bones, we are getting little lines where it looks like their brains are made out of corduroy. Partial volume artifacts, I think we've talked about this to some degree. This is when more than one kind of tissue type is within the area of a voxel, and the best way to reduce these artifacts is to use thinner slices. When we used the older CT scanners had detector banks where we could not avoid having long z-axes on our images. We could not have isotropic voxels, right? What do I mean by isotropic? So this is our x-axis, our y right here, and then this over here is our z-axis. This is not an isotropic voxel because the x and the y-axis are more or less the same distance, but the z-axis is much longer, right? So if, for example, there was something inside of this voxel, right, that's of a different attenuation value, it's going to average that out across that entire area. It's going to average that out across that entire area. Versus if we have voxels that are of the same size, you can see that now it's going to appropriately sample the voxels and be able to detect that element there. So again, the best strategy is to use thinner slices. Edge gradient artifacts, these can be difficult to detect, but a common place to look for them is in the air-filled stomach, because a lot of times we'll have some barium in that area, so it's attenuating a whole lot of photons. The air is not attenuating any photons, and then right next to it we have the liver, which is this massive kind of flat or uniform density. So what the CT scanner will do is actually project some of the air from the stomach into the area of the liver. As it sampled that, it had a difficult time seeing where the edge was between the stomach and the liver. So it's like a streaking artifact, and we just see it kind of a gradient over there. Motion artifacts. This is when the patient moves. Sometimes we call it ghosting. This is a true coronal view of the sinuses. So the patient is laying on the CT table like Superman, only their head is straight up in the air. It's a very uncomfortable position to be in, especially if you have any kind of stuff going on in your sinuses. So this is a common place to see motion if a patient's talking or having a difficult time breathing in that position. We can, overt patient motion is the best way to diminish that is just preparing the patient, giving them appropriate instructions. Please don't move while we're doing the CT scan. It's important for you to hold still so we get good pictures. Involuntary patient motion is stuff like people farting while they're on the CT scan table. That will cause motion on the images. There's a lot of internal farting that people do, and that can cause a lot of motion on the images, right? It's like the stuff has to fart from the small intestine to the large intestine, and you get motion there, and if you're trying to find their appendix, that internal fart can cause problems, right? The best way to reduce that is, and we're going to call that involuntary motion, not internal farting, but the best way to do that is to reduce the scan time to something that's as short as possible, right? My dad was telling me once he was talking to a patient about what was his heart history and stuff like that, and this fellow was reporting, and he said, I don't know about anything that's going on with my heart, but the doctor once told me I had a massive internal fart. He was trying to say that he had an MIA, a massive internal infarction. Okay, metallic artifacts. So I mentioned it's very, very important, even though the CT scanner can see through a lot of metal stuff, not to just bank on that. Have the patient remove anything metal. They cannot remove their hip replacement or like dental hardware. They can't. Don't say, please remove your gold teeth before getting in the CT scanner. But just be aware that those things can cause streak artifacts on the images. The best way to do that is to remove any metal. As a rule of thumb, though, I typically do not ask female patients to remove any piercings below the nipple line, right? Or maybe below even the shoulder line, right? You will get those patients who ask you all those questions. Please let them know it's probably just fine. We should be able to see everything that we need to see. Those are interesting conversations. If it's not removable, please just, if need be, you may need to angle the gantry. So we used to do what we call butterfly views. If a person had a whole lot of hardware in their mouth, a whole lot of dental implants, we would do butterfly views where we would angle the gantry in different directions in order to see around it. Out of field artifacts. So we can see this pretty clearly on this image here. What's happening in these two images is probably the patient on our left may have their arms down. Right? So the presence of the arms outside of the scan detective field is going to create an artifact. The machine is not able to compensate. It's not able to say, what is that? It can't clearly delineate it, and so it's creating an artifact. So having the patient's arms up for CT scanning is very helpful to avoid those out-of-field artifacts. Even just defining a display field of view or a scan field of view in which anatomy is clipped can create an out-of-field artifact. If I haven't told the scanner to scan the entire area of the skin margin, having skin margin outside of that field of view can cause an artifact. Ring artifacts. Typically these are imperfect detector elements. You see them as scanners start to get older. It can also have to do with calibration problems. So older GE scanners, I've worked on a lot of like 2-row or 4-row GE CT scanners. This was a common thing that you would start to see, especially if you're trying to do something with smaller cuts like a wrist or temporal bones, which is like the last place you would want this artifact is on an image like that. You can try recalibrating the machine. Generally the machine has already started kicking out calibration errors because it can detect this. But you can see this is just the water phantom that they've scanned. And you can see if I were to place an ROI here versus here, I'm going to get some different readings when I should be getting all the same reading because it's all the same. It's just water. Tube arcing. This is not good stuff. And generally, if you're getting this kind of thing, your CT scanner tube is it's about time to replace the tube. So it can happen from gas or from elements, free-floating elements inside the tube. Like so, as X-rays are being produced, if I've surpassed the heat load on the tube enough eventually I can start to wear down the anode of the X-ray machine, and particles of the anode have now been vaporized by the heat that's being produced as I'm making X-rays. They're floating around inside the tube, and it will start to arc. That means that if you were to actually open this thing up, it would look like something out of Frankenstein's laboratory. Right? There would be electrical arcs. It would look like a little thunderstorm in a bottle. Right? That's not a good thing. That's not what you want to see inside of your CT scanner. So high voltage arcing, we want to be very careful about the kind of electricity that's going into the CT scanner, that there's no power spikes or bumps in it. And then we also want to be very careful with making sure we're not regularly exceeding heat unit loads on the CT scanner. It will tell you if it's hit its heat limit. These can be very minor, or they can be very severe. Typically, it's going to produce an error message. It might even shut down the machine. It may require some kind of service call, or eventually the replacement of that tube. Spiral and cone beam effects. This is not related to like cone beam CT that they do in radiation therapy. This is related to specifically to diagnostic CT. So as they use that word cone beam, just be aware that I'm talking about from a diagnostic point of view. This is only for helical scans because it will use a fan or a cone beam for helical scanning, and it has to do with interpolation or the reconstruction process. It doesn't have enough information, so it's putting other junk in there. So the difficulty with this is it's going to create very subtle differences in the CT images, and those could be construed as pathological when the radiologist is looking at those images. The best way to avoid this kind of stuff is using a lower pitch. So again, we've defined a pitch range of 1 to 1.5. If we go over 1.5, we may start to see this artifact. Sometimes it's called like a windmill artifact. She has a picture of it later on in the chapter, page 79, of what it looks like. So windmill artifacts are caused by a cone-shaped rather than fan-shaped X-ray beam. It's just misregistering stuff as the table progresses through the tube. We would see it more pronounced on the outer detector rows because they're not receiving enough information. And so this is one of the reasons why when we have these bigger CT scanners like a 64 slice or a 228 slice CT scanner, with some protocols we may not use the entire detector array. We may only use a portion of the detector array in order to avoid having this kind of artifact. All right, that's it.